Hi, I'm presenting a case of a patient who was treated in Rabin Medical Center. This is a 63-year-old female patient married with 4 children who resides in northern Israel. Until recently, she worked as a kindergarten teacher assistant. She is physically active and also a smoker for the past 25 years. She is menopause, and her history is notable for past femoral DVT several years ago. This patient initially arrived to Zif Medical Center in Zefad in northern Israel, and she complained of mild dry cough for the past 3 weeks. She denied fever, wheezing, night sweats, weight loss, or change in bowel movements. And there was also progressive F4 dyspnea for the past 2 weeks. She denied paroxysmal nocturnal dyspnea, she denied orthopnea, she denied rest dyspnea, pedal or facial edema, and also recent flight or immobilization. This patient also denied chest pain or palpitations. On first physical examination, we noticed mild dyspnea. She had a respiratory rate of 18. The blood pressure was borderline with 107/70. And she was mildly tachycardic with a heart rate of 108. The physical examination was unnotable. There was no jugular veins distension. The heart rate was regular. There wasn't pedal edema, and the abdomen was soft without splenomegaly or hepatomegaly. This is the blood examination. We noticed anemia with hemoglobin of 11. And also elevated lactate dehydrogenase, 968. There was mild elevation in liver enzymes, but with normal bilirubin and albumin. Initially, the patient went through a chest X-ray and later on an echocardiography. This is the echocardiography from Zif Medical Center in Tzfat. And we can see that for those of you who are not familiar with echocardiography, this is the long axis view. This is the left chamber, the left atrium, the aorta, and this is the right chamber of the heart. We can see that there is a big mass occupying almost all of the outlet tract of the right chamber. And there's also, we can see that there's also a pericardial effusion. This is another view of the heart from short axis. We can see the left chamber, and we can see this is the right chamber, and there is a very big mass occupying almost all of the right chamber. This is a higher view with the aortic valve in the middle, and we can see that this mass actually surrounds the aortic valve. And yet another echocardiography view. We can see this is the right chamber, and the mass is infiltrating the wall of the right chamber. This examination was followed by a CT, and here we can see the CT of the patient. This is the right ventricle, and this is the mass. It's a very big mass, which almost occludes the right ventricle and infiltrates the wall of the right ventricle. Another higher view, this is the aorta, and the mass actually surrounds all of the aorta, compressing the superior vena cava. In the coronal view, we can see that the superior vena cava is compressed by the mass in the right atrium, and there's also some protrusion to the right ventricle through the tricuspid valve. And another interesting feature of this mass was sparing of the right coronary artery. This is the right coronary artery, and it is surrounded by this mass. It looks homogeneous. Another last view. This is the right coronary artery, and the mass which surrounds the right coronary artery. So when talking about differential diagnosis of cardiac tumors, we divide it to benign and malignant tumors. So from the benign tumors, the most common is myxoma. More than 75% of benign cardiac tumors, but myxomas are usually found in the left atrium. And in this case, the tumor was infiltrating the ventricles, so we thought that a benign tumor was less likely. When talking about malignant tumors, we divide malignant tumors to metastatic tumors, infiltration of the heart, and primary cardiac tumors. The most common tumors which infiltrate the heart metastatically are RCC, melanoma, breast cancer, lung cancer, sarcoma, lymphoma, and leukemia. Also, it seemed that this was not the case because we did a total body CT and there weren't any bulky tumor nowhere else to be found except the heart. When talking about primary malignant tumors of the heart, the differential diagnosis is between sarcoma and lymphoma, with sarcoma being much more common. So on this point, to summarize, we had a patient with a very large cardiac tumor, which was still stable hemodynamically and respiratory, but it seemed that she was on the brink of catastrophe. She was tachycardic, the blood pressure was borderline, dyspneic with even the most mild effort. So we had several clinical dilemmas. The first one was how to get a tissue sample, and we decided to go to open thoracotomy. She went through the surgery quite well. Biopsy was taken, and the feedback of the surgeons was that there was a very bulky tumor, which seemed very hard. They were almost positive we're talking about sarcoma. The next clinical dilemma was whether to administrate an empirical therapy or to wait for tissue diagnosis. We decided to wait because there was a differential diagnosis and empirical therapy was not administered. And indeed, several days later, we got the tissue diagnosis. So you can see on the left panel, these are large lymphocytes with scanty cytoplasm. And on the right panel, which die positively for CD20. And the diagnosis was a large B-cell lymphoma, diffuse large B-cell lymphoma, primary cardiac lymphoma. And actually, retrospectively, when talking about the CT, there were several signs to point out that it was actually a lymphoma and not sarcoma. The first one was the location of the tumor. We know that lymphomas are usually located on the right side, on the right heart, and sarcomas on the left heart. The second one was that the tumor was homogeneous, which is typical for lymphoma. Sarcomas are usually have a lot of necrosis and hemorrhages inside them. The third feature was poor enhancement after contrast administration. And the fourth feature was that this tumor respected borders. It spared the right coronary artery. And this is something which is more typical for lymphoma and not sarcoma. So when talking about primary cardiac lymphoma, this is a non-Hodgkin's lymphoma presenting as a cardiac disease, especially if the bulk of tumor is intrapericardial. We know from autopsies that about 20% of patients with lymphoma have metastatic infiltration to the heart. But when talking about primary cardiac lymphoma, this is much more rare. It comprises only about 1% of primary cardiac tumors and only about 0.5% of extranodal lymphomas. It is more common in immunocompromised patients. Actually, data in the literature is very scarce, so almost all of the data is derived from case series, with the largest case series being 9 patients. So this is a paper which was published in Cancer and collects all case series from 1949 to 2009. And they collected 197 cases in 60 years. It was more common in male patients. 92% of patients had involvement of the right heart, and only 7% of patients had only the left side of the heart involved. That was really rare. The most common non-Hodgkin lymphoma subtype was DLBCL. Okay, so returning to our patient, the patient was transferred to treatment in hemato-oncology in Rabin Medical Center, and she started receiving R-CHOP protocol. By now she received 2 courses of R-CHOP, and she's feeling much better clinically. This is the follow-up echo, and we can see that this is the subcostal view. We can see that there is almost no sign of the tumor in the right heart. Okay, and another view. This is the inflow of the right ventricle. Okay, and we don't see the tumor. And here we can see that the right heart is free of tumor. Thank you very much.